So, we're talking about syndesmotic injuries of the ankle. As mentioned, kite surface, severe twisting injury, right ankle, acute swelling, unable to wait there. So you might take an X-ray. Draw a few lines there for you. You're looking at the reduction of the syndesmosis, the junction between the anterior part of the tib-fib joint and the posterior. You're looking for the overlap, medial opening, and it may actually, in fact, be normal. So I'm not actually talking about whether C fractures were inherent to that, you have a syndesmotic injury. I'm talking about isolated syndesmotic injury. Be aware that, I'm sorry, all the diagrams are going to be weird now. Consider doing an MRI if on clinical examination you find you suspect a syndesmotic injury. So always look for pain at the tib-fib joint, and importantly pain that radiates more proximally into the interosseous membrane. In this situation, you might want to consider doing an MRI. So this MRI scan shows an inversion injury with typical lateral ligament ATFLs, CFL sprains. You get a typical deltoid crush mechanism on the contralateral side. But look at the syndesmosis. So there's, in this patient, a rupture of the anterior tib-fib joint, and there's also edema that goes up into the interosseous membrane. There's also a bit of an osteochondral bruise there as well. So what is an acute syndesmotic injury? What is diastasis? It's any loosening of the connection of the distal ends of the tibia and the fibula. It can be partial, it can be complete. It's usually due to an external rotation or a hyperdorsiflexion force. And in the literature, it's actually about 15% of all ankle sprains. So in my view, I think it's actually underdiagnosed. So it's something that we should all be quite aware of. The anatomy of the ankle joint. The anterior-inferior tib-fib ligament confers 35% of the stability of the joint, as opposed to the posterior part. The posterior has a superficial and deep part, and together they make up about 42% stability. The interosseous ligament itself confers about 1/5 stability. So there's some diagrams there. Consider shifting the talus 1 millimeter. It actually decreases your tibio-talar articulation by 42%. If you have complete disruption and tear of the deltoid, it decreases 40% in the tibio-talar contact area. Conversely, it increases your tibio-talar contact pressure by 36%. So what it shows is any significant shift more than 1 millimeter or 2, you'll get significant changes in contact pressures, contact forces through your ankle. It increases your arthrosis rate. What are the examination signs for an acute syndesmotic injury? I mentioned localized pain. Consider the squeeze test. There's a squeeze in the lower calf between the tibia and the fibula, and you get pain that either radiates to the joint or up more proximally. Rule out the medial ligament injuries or a proximal fibular injury. You're aware of the external rotation test. So if your hand on the leg supporting, apply an external rotation force at the foot, it should also reproduce pain. But most of all, have a high index of suspicion. We talked about the X-ray imaging. You can do AP and mortise views. But in general, an X-ray actually has a high false negative rate. We talked about the medial clear space should be less than 4 millimeters. The tib-fib clear space should be less than 5 millimeters. And the overlap between B and C should be more than 10 millimeters. So MRI is definitely more sensitive. It picks up approximately 96% of injuries. It will give you a very good idea of rupture of the either partial or complete of the anterior, posterior tib-fib ligaments, and an idea of whether the force has propagated more proximally into the interosseous membrane. The role of arthroscopy is actually becoming more prevalent, and I do believe that it is probably the gold standard. If you have opening at the joint and you can directly put a probe in, if it opens up more than 1 to 2 millimeters, that is abnormal. I might show you a video of it later. We'll see if this works. And these are some static pictures. So this is an arthroscopy, and you can directly probe. You can see there's maybe even a small little chondral lesion there. There's definitely opening there of 1 to 2 millimeters. And on the video, you'll see by applying an external force, just moving the fibula around, there's massive translation. You can get translation not just widening, you can get abnormal translation in anterior and posterior planes as well. This diagram here is post-reduction, so I usually use large talcott, reduce it, and you can see that the joint is completely congruent post-reduction. Everyone knows how to put a diastasis screw in. So my summary of management of acute syndesmotic injuries: number 1, have a high index of suspicion. Look for it in the history. Usually it's a higher grade sprain. They have medial and lateral ligament injuries, which you usually suspect, but also think, is it a high grade? Think of the syndesmosis. In your examination, first up you get an X-ray. If it's positive, well, that's easy. I'm actually scoping these and debriding the joint, because often the ligament actually flips in, and you can clear all the debris out. You can see it completely reduced, and fix it with the screw. If it's negative and you're suspicious, get an MRI scan. If the posterior tip of ligament is normal, that we mentioned gives us about 42% stability. And if the interosseous membrane is negative, then I would agree with bracing for 4 weeks, rehab, etc. However, if it's positive, if you have a partial or total tear of the posterior part, I scope these, and if they're open, I fix them. You want to avoid chronic syndesmotic injuries because all options, be it subacute or chronic, is poor. In the subacute setting, you can go back in, you can debride it, you can try and insert a screw, you can supplement it with tendon graft. In the chronic situation, you can still do a reconstructive procedure, or you can actually fuse the joint, but in both the results are poor, unfortunately. So I've got